Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto. Today, I'll be discussing some of a challenging case with Professor Andrea Doria and Maria Dall'Era, both from the Lupus Academy Steering Committee. Andrea and Maria, thank you so much for joining us and welcome. So let's discuss one case of lupus. And Andrea, this case is yours from your clinic, so you have more of the insight of the case, and I'm going to describe it a little bit. So in July 2010, a 32-year-old female started to experience fever and headache. 1 month later, in August, she developed subacute cutaneous lupus on upper arms, leukopenia and thrombocytopenia with inflammatory arthralgia, mild and transient arthritis at hands and wrists. Her blood test revealed mild leukopenia, 3046-7, low C3, 79, high gamma globulinemia, and she also had positive anti-nuclear antibodies, anti-dsDNA, anti-ESA, SSA or RAW, anti-P ribosomal, and rheumatoid factor. She was diagnosed with lupus, systemic lupus erythematosus, and treated with 25 milligrams of prednisolone that was tapered to 5 milligrams a day, hydroxychloroquine 400 milligrams a day, with improvement of the disease. During the follow-up between 2010 and 2014, she continued to experience mild but persistent inflammatory arthralgia in her hands. She had started methotrexate in May 2011, but she withdrew it after a few months due to gastrointestinal side effects. In May 2015, so 5 years after the initial presentation of SLE, she fled again with subacute cutaneous lupus and arthritis in the hands and wrists, and she developed Jaccoud's deformities. Her laboratory exams revealed now moderate leukopenia, 2,300, pretty high anti-dsDNA antibodies with a titer that was almost 200, and low C3. Her activity index at the time were SLEDAI-2K 11, CLASI activity 10, DAS28 458, and she already had 1 point of damage, the Jaccoud's deformities. She was on prednisolone 50 milligrams and hydroxychloroquine 400 milligrams. So when we listen to this evolution, and from the beginning, I don't know what you both think, but empirically, I would tend to feel that this is not a severe lupus case. She had only skin and joints, which is clearly wrong. She was severe with these manifestations. So the lupus was not controlled. She already has damage, and she's needing prednisolone, sometimes above 5 milligrams a day. So, Andrea, obviously, she won't go again for methotrexate. So what treatment have you considered back then, and taking account that it was 2015?
Yes, first of all, Raquel, I have to say that this is true. It is not a severe case if you think that a severe is renal and neurological. But I think that it can be defined as a severe non-renal lupus. So it means that it is a picture which can potentially evolve. And so I think that these patients deserve the best that we can do for her. And so I think that that patient should be treated with the combination of a traditional immunosuppressant and a biological drugs. Mm-hmm. Of course, at that time, we only had the belimumab. And so I think that the ideal treatment for these patients is methotrexate and belimumab. Unfortunately, I understood that, or I do not remember very well these patients. I followed her many years ago, and so I realized that she didn't tolerate methotrexate because she developed gastrointestinal manifestations. And so an option could be leflunomide, for example, in these patients, or another less, in my opinion, also MMF could be another option. I use very rarely the azatioprine. So I think that in these patients, as a traditional immunosuppressant, I would have used leflunomide, or first of all, we can also try to give her again methotrexate, for example.
Yes.
And if again she does not tolerate methotrexate, to try leflunomide or MMF. In any case, in addition of the traditional immunosuppressant, I would have used at that time belimumab.
Okay, Maria, would you have done anything different back then? Do you have any additional comments on this case?
I agree completely. This is a woman with non-organ threatening SLE, but has severe manifestations and already has had joint deformity. She's had Jaccoud's arthropathy. She's already incurred damage, as Andrea spoke about. She's required a too high a dose of glucocorticoid than we would like, which also will contribute to ongoing damage. So for all those reasons, I agree exactly with what's been said, that we have to think about altering her course of therapy to achieve better disease control. And these patients can be very challenging to treat, particularly the arthritis. I think in terms of what we could do, I agree with the choices. The other thing that I've had some success with in my patients who have not been able to tolerate oral methotrexate is to try subcutaneous methotrexate. And often it's interesting, they don't have as much of the GI side effects. They can have some of the other side effects, because sometimes with methotrexate, our patients can also have fatigue for 24 hours, kind of a flu-like syndrome for 24 hours after taking the methotrexate. I found that with the sub-Q formulation, they can still have some of that, but they don't have the GI as much toxicity. So in my patients who have the GI toxicity, I can try the sub-Q. And sometimes that can be very effective because it also has a better bioavailability. But then I agree. I think this is a patient who she's already had clear-cut damage. We're into the disease course. She's on too high a dose of glucocorticoids than we would like her to be on to control her disease, and thus initiating a biologic therapy in concordance with what we're talking about with the conventional immunosuppressants. And I agree 100% that belimumab makes a lot of sense to start here.
So let's go back to the patient. And she was started on belimumab. And in May 2017, she experienced her first flare after 2 years of belimumab with diffuse subacute lupus on the upper arms, chest and back after sun exposure. And she was having persistent arthritis. Lab exams right now, during May 2017, they had leukopenia, not severe, so 3,700. She has again elevated anti-dsDNA with more than 100 units per liter, and the complement C3 was again low. So the index now were SLEDAI-2K 10, CLASI activity 11, DAS28 4.28, the SLEDAS was 696, and she continued having 1 point of damage, the Jaccoud's deformity. And she was on 5 milligrams of prednisolone, 400 milligrams of hydroxychloroquine, and she was doing belimumab endovenous 20 milligrams per kilo every 4 weeks. Andrea, first of all, this is the first flare for belimumab after starting belimumab. So do you think this could be seen as a belimumab treatment failure, or just a flare on belimumab that could be less severe, and we don't know how she would be if she was not on belimumab? And do you think that right now a good choice would be to change your treatment decision?
No, I definitely think that is a flare during the belimumab treatment, and I do not think that she's a failure, a belimumab failure. What I think is that I mentioned before, probably in these patients, it would have been better to start a combination therapy, and not only belimumab as probably we did at that time. And so I think that is probably one reason for the disease relapse. But in this case, I think that since we, at that time, we had no other options for biologics, I think that I could have added a standard, a traditional immune suppressant, as mentioned before, maybe or leflunomide, or we start methotrexate. But Maria, I almost exclusively use the subacute methotrexate.
Methotrexate.
Very, very rarely I use oral methotrexate, just when sometimes when they do not tolerate the subacute, I switch to the oral, but I usually start with the subacute. I do not know what is also your Raquel and Maria habits, but I almost start with the subacute because I know that is much more effective. There are less also because you know that the methotrexate can have some conflict, some with the interaction with the food. So in this case, you can also try to again, if the patients use the subacute, we can try to use the oral one, or we can use the leflunomide, or the other option could be the MMF. But I do not think that patient is a real failure to belimumab. In any case, at that time, we had no other option. The other option that we could have at that time is the rituximab, which could also be an option. But I really, since in Italy, in Padova, at least in Padova, I have a very great difficulties in obtaining rituximab because it is off-label. And so after 2 or 3 patients that we can treat during the year, then they say it is not more off-label if we have to use them in many patients. And so I think that the option, I will try again methotrexate, oral methotrexate, and if not, leflunomide or MMF.
So I'm just doing a small question to you, Maria. What is your experience with methotrexate? First oral, then subcutaneous. What's your experience like? Andrea was asking you. And the other thing is there any case where you would do rituximab during a flare and then restarting belimumab again? Like, do you have that practice?
Great. I think it's interesting to hear about different people's practices with methotrexate. And interestingly, I think it makes a lot of sense, as Andrea discussed, to start with sub-Q. We tend to start with oral. That's just been the practice where I am. Interestingly, we start with oral and we try that first. And then we go to subcutaneous if our patients cannot tolerate the oral. I think there's a strong argument to be made to start with sub-Q as well, because the bioavailability is better, less drug-drug interactions, as Andrea described. But our habit here, our practice has been to start with oral, interestingly, but then to escalate to subcutaneous if necessary. And I do have patients that are able to tolerate oral methotrexate. And again, we have to try to get them up to about that 20 milligram a week dose before we would consider someone to not be responsive. I think that's one mistake that I think some of our trainees, when they're learning about how to take care of our patients, they don't get the dose up, right? So they use a small dose and they say, my patient's not responding. Well, you have to get the dose up. Orally, you have to try sub-Q before you deem a patient not to be responding. And then I just want to say, I think what's interesting here about this case is she did very well for 2 years, right? from 2015 to 2017. And then when she had sun exposure, that is when she flared. And she flared with her subcutaneous lupus as well as her arthritis. And so that always makes me think about, gosh, getting back to basics and kind of re-educating about sun protection, because so often in our clinics, we get very busy, at least in my clinic, and sometimes I don't have the time to review those basics. How can we prevent flares? What if she could just stay on these medications that she's on, and she can take more protections in terms of the sun exposure, which it seems like flared these active disease manifestations in 2017. So that was one thought that I had as well. I think with the SCLE also being a component of this, I could also think about trying to switch out the methotrexate to, for instance, MMF, because which is very good for the skin. And some people do have a response to MMF with their joints. Not all. MMF is not as good across the board as methotrexate for the joints, and that's why we don't start with it. One could try it. And then I agree in terms of the question about rituximab, we do not use rituximab at my center for non-organ threatening SLE. It's not approved in the United States for the treatment of lupus, so it's very difficult to get. But in situations where we run out of options, yes, we could try it. And we do have experience using the combination of rituximab followed by belimumab, as you just asked, Raquel. The experience that we have is in lupus nephritis, which is where we studied it in the Calibrate trial. And but there are other trials in which it's been used in non-renal lupus, such as Beat Lupus, for example, Bliss Believe. None of those trials were overwhelmingly successful in terms of the primary endpoints. But I think it makes biologic sense to use belimumab concordant with rituximab to suppress B-cell repopulation. I think it makes a lot of sense. But this is not the typical patient that I would reach for with rituximab for the reasons that I described. It's not approved in the US, difficult to get. I think we have other options now.
I also agree with Maria that we have used, for example, the sequential therapy, especially in patients with nephritis. Maybe patients who were on belimumab and flare with nephritis, or where the nephritis appears during the belimumab treatment. In those cases, we use rituximab, and then we start again belimumab. So we have treated some patients with this protocol. By contrast, Raquel, I would like to ask Maria, because I do not agree with her to use the oral methotrexate first. Because if we think that the subacute is more effective than the oral one, when I have not to use before the subacute, so it guarantee me the best result, and to use oral only if the patients do not tolerate very well the subacute. Also because when you use, yes, it is 6 pills per week. Is it not so much? But we know that our patients are taking a lot of other pills. And so I think that the subacute also from this. And then I am really a little bit worried about the interaction with the food, because the oral should be, the pills should be taken before meals, and which can, and I'm not sure that all the patients take them before the meals.
I can comment on our reality now, and we also tend to start with oral, but that as a cultural background, because subcutaneous methotrexate is only refounded for patients for 5-6 years. So The pills were refunded, so it was cheaper for the patients, but the subcutaneous was not refunded. So the patients wouldn't take because it was too expensive. But now both of them are refunded, and I think we are just glued to the cultural practice, but it tends to change.
I agree, but I think that there is a lot of evidence and data to support exactly what you're saying, Andrea, that the subcutaneous administration makes a lot more sense for the reasons that you said. But I think it is habit and practice in the United States to start with oral. And perhaps what we should be doing is giving our patients more of that preference up front. There's some of my patients who just do not want to do injections, and I have that even with belimumab. It's very interesting. They still want the infusions, even though to me the infusions seem to be much more inconvenient to have to go to the infusion center once a month. There are some patients who don't like to do injections at home. Some do. But I think we have options for our patients, and I think it's important to give them options. And I think you've made some great points, and it's making me think that starting when I start methotrexate, I should start giving that option of also doing the sub-Q. I think that makes a lot of sense.
The only thing, Maria, is that the subacute methotrexate, as Raquel mentioned, is much more expensive than the oral one. Do you know that in Italy, the 20 milligram of subacute methotrexate is more expensive than the adalimumab biosimilar?
That is shocking.
Shocking.
Yes, also in Portugal. Yes.
Also in Porto.
But now it's refunded. So
yes, and by Italy is refunded. Yes, it is reimbursed completely.
So let's go again to the case. And I don't know if you that are listening to us remember, but the patient just had a flare on belimumab after sun exposure. So the decision back then in, I believe, 2017 was to continue belimumab infusion and adding MMF, mycophenolic mofetil, 2 grams a day, and she progressively improved. And after 3 years, so she was very good for 3 years, now we are on August 2020, following her 17th course of belimumab treatment, she had a mild skin involvement, a few little red lesions on her left arm. The Jaccoud got worsened, the deformities, and she is having now inflammatory arthralgia and right wrist arthritis. The lab tests showed a positive dsDNA, almost 100. She had leukopenia, 2090, C3 and C4 were now on the normal range. So she was not as active as with the previous flares that we described, but she had activity. And the index now would be a SLEDAI-2K of 6, a class E2, DAS28 3.36, the SLEDAS 5.5, and she doesn't have new damage. She's having 1.4 the Jaccoud. And she received ongoing 5 milligrams of prednisolone, belimumab every other week, every 4 weeks. And hydroxychloroquine was still on the 400 milligrams a day and MMF 2 grams a day. Andrea, were you happy with this result for the last 3 years?
Not completely. Not completely. I think that she is not in clinical remission. She is not in low disease activity even. And so I think that we have to make an action. And at this point are not so many options we have, or we can increase a little bit for a period of time the dosage of MMF, but rarely use a dosage higher than 2 grams in patients with a non-renal lupus. But again, this could be an option. Or we can again try to switch MMF to another traditional immunosuppressant, or again MMF, methotrexate, or lefunomide, or azatioprine. Or we can tried to change the belimumab. Belimumab at that time, unfortunately, we have only belimumab approved for SLE.
Mm-hmm.
An option could have been to use rituximab in this patient if you wanted to just to give immune suppressant boosts, just in order to induce a new clinical remission. So maybe, as Maria mentioned, probably she's not so careful in using sun protection, probably if she develops every time the skin manifestations.
We already discussed before the sequential treatment of rituximab, belimumab, rituximab, but something that also worries me is she didn't tolerate methotrexate. I don't know if the MMF is really being taken correctly, but Maria, can you please comment on this stage? We have more than 5 years of belimumab now. What would be your options?
I agree. I think this is very challenging. We do have the luxury now in 2024 of having another biologic agent that was not available to Andrea back when he was treating this patient. But now, of course, we have anifrolumab, which I think would be an option now, which was not an option back then. But one could try again because she is having active skin, which we know responds very well to anifrolumab. And anifrolumab has also been shown to be effective for joints. It just isn't as tremendous an effect as in the skin, but there is an effect, and that's been shown in post-hoc analyses from TULIP-1 and TULIP-2. So that would be an option now, but I agree, back then, that was not an option, and I think it made a lot of sense to switch to rituximab, to give that a try, to see if one could get that approved and paid for and try that. And then just continue the belimumab. I think we talked about that, right? So add in the rituximab, continue the belimumab, because there is a role for sequential therapy in prolonging the time of peripheral B-cell repopulation after the rituximab. So that makes a lot of sense to me. And we can see how she does. And then I think you mentioned this, Raquel, the question, or you hinted at the question of adherence. You know, MMF is a very challenging medication for people to tolerate, and often, despite their best efforts to try to take it, it is challenging. It can have a lot of gastrointestinal side effects. And so trying to understand how much is she actually able to take, and is it reasonable to try and continue taking it, or do we peel that back? You know, all of those questions. And I think the overarching issue that I see here that's challenging is, despite the fact that she's having these flares of her subacute cutaneous lupus, she's having flares of her inflammatory arthritis, she continues to have progression of the Jaccoud's arthropathy. And that is such a fascinating manifestation that is poorly understood, in my opinion. At least I poorly understand the pathogenesis. And often we see patients in whom their inflammatory arthritis appears to be controlled clinically, but they continue to have progressive Jaccoud's arthropathy, implying that there are different pathogenic mechanisms that are leading to progressive Jaccoud's arthropathy. And how do we actually treat that and prevent progression? I think this is a very important area of research. And when I talk to people who are much more expert specifically in Jaccoud's arthropathy, I think they also don't know exactly what the pathogenesis is and how to treat it. And we have studies that are giving us some hints about pathogenesis. And there was a very nice session at the ACR Convergence just last month, specifically on arthritis, and looking at studies of synovial fluid and some synovial biopsies in arthritis, giving us a hint of changes and in gene expression and differences in gene expression between the different forms of arthritis. But I think we still have a lot to learn. But all of that is to say, I agree that this would have been a patient in whom rituximab makes sense because there weren't other options for biologics at that time.
Andrea, there's something that I just mentioned on the beginning, and in lupus patients, sometimes on the clinical practice we struggle with. So rheumatoid factor positive lupus patients and arthritis that does not look like rheumatoid. Do you have any comments on this?
You means that the arthritis look like a rheumatoid arthritis?
No,
Oh,
that does not look like rheumatoid, but has rheumatoid factor.
yes. So you mean that the patients continue to have a relapsing remitting arthritis, polyarthritis, but not erosive? So
Yes, and then there's that rheumatoid factor
yes. As you know, rheumatoid factor, for example, is very often associated with anti-Rho SSA. And so it is an option that the patients has an associated anti-SSA antibodies and maybe a Sjogren syndrome associated
yes.
with lupus. But the rheumatoid factor is a specific effectors of the innate immunity, and so yes, it is possible to find it also in SLE, but without any association with the rheumatoid arthritis features. By contrast, when they are associated with the rheumatoid arthritis features, now we have the classical phenotype of the lupus syndrome, but it is another story.
Would you change thinking of this case and all that we have discussed till now? Was there any change if the patient had lupus and clinical features of clinical and radiological features of lupus? Would the options that we discussed be different?
Yes, I think that I could have used rituximab probably earlier.
Maria, are you thinking of any other option that would be different?
I agree. I think starting with methotrexate makes sense. We use that in our rheumatoid arthritis patients as well, but then we quickly add on biologic therapies. And I think in this case, I agree, perhaps rituximab perhaps would have been earlier. It's tricky because the MMF was also helpful for her skin manifestations, right? But perhaps rituximab with MMF earlier. I think if it ended up that she had more of that lupus, that true overlap between erosive rheumatoid arthritis and lupus arthritis, then my comment about anifrolumab would not be as relevant. We would go more down the treatment paradigm for classical rheumatoid arthritis. And the other thing I was going to mention was I have had patients with refractory inflammatory lupus arthritis, not the overlap with RA, that have responded well to abatacept. And in the United States, abatacept, again, is not approved for the treatment of lupus, but we use it in an off-label fashion. And there are phase 2 data in lupus, as we all know, that showed efficacy in the subgroup of patients with lupus arthritis. So I have actually added that on to methotrexate instead of rituximab, or if rituximab doesn't work effectively enough. That's another option that I have found specifically for lupus arthritis that works well. But what I don't know is this Jaccoud's arthropathy and how to halt that progression, and which of these agents that we're talking about will truly be effective for that. I think what we need to do is at least treat the other manifestations that we see in front of us, her subacute cutaneous lupus, her classical inflammatory arthritis. And by treating those manifestations to the best of our ability, the hope is that we will also be able to decrease progression of Jaccoud's. But again, I have some patients who everything else is treated very well. They're on very good immunosuppressive therapy, but yet the Jaccoud's continues to progress. And those are mysterious to me. How can we understand those patients and stop that progression? Because it can lead to significant deformities and significantly reduced quality of life. I have a patient who is a phenomenal painter, and that's how she makes her livelihood. And she cannot paint anymore because of her Jaccoud's arthropathy. And we're doing everything we can in terms of conservative measures, joint splinting, for example, occupational therapy, but it can be quite problematic. And how can we prevent that from happening?
Can I
Yes, of course, Andrea.
Allora, because the abatacept is really interesting. I remember that in the phase 3 abatacept, which failed, the only domain which was effectively respond was arthritis. There was a significant difference among the two arms. Another option, Maria, could be in these patients, just in order to think at off-label therapy, for example, upadacitinib.
Yes.
Recently succeed in phase 2, 3 trials. Maybe could be another off-label option in these patients. The other
Yes.
that it is true, I agree with Maria that the Jaccoud arthropathy is really a mystery. And it is mystery also not only from the pathogenetic point of view, as you mentioned, Maria, but also from a clinical point of view. Because, for example, I think that these patients represents what classically we are used to see. A patient with inflammatory arthralgia, who developed the Jaccoud arthropathy in many years, and we were not realizing that she is developing and so we see the patients with this inflammatory arthralgia, and then during a visit, we realized that the patients has developed suddenly a Jaccoud arthropathy. But I think that probably the patients had an inflammatory process, maybe a subacute inflammatory process which progress slowly until the development of Jaccoud arthropathy.
And Andrea, I'm sorry, Raquel.
Sorry, you want to think about that? You can comment then. That
I would love to ask Andrea, because that's making me think about something that I perhaps should be doing more in my practice, but it's been challenging. And I would love to hear your experience. Are you doing more advanced imaging to detect some of that subclinical inflammation? Because perhaps that is what we should be doing. And I agree with the Jaccoud's arthropathy, and you look at the imaging studies that show predominantly, tenosynovitis of the flexor tendons, pericapsular inflammation, not so much the synovitis, but there is inflammation in other compartments. And I have to say that I have not been doing, serial MRI, ultrasound, but perhaps I should be doing that. But what has your practice been with that?
If I have to be honest, Maria, I didn't perform either RMI but we have started now to use ultrasound. Like in rheumatoid arthritis, we have to introduce the use of ultrasound also in the care of lupus patients. And I think that in the future, in the next few years, we could understand a little bit more about the Jaccoud arthropathies.
What I was going to comment is that because Jaccoud's arthropathy is a damage point on the scores, empirically, when you see one, you think this is damage. And probably it's escaping to us the process that is progressive, and we are not taking care of it as activity because it's a point on damage. And probably this may induce a bias to our practice during the clinic. And so, should we return to the case right now, or do you want to comment on this?
No, I think that's such an important point, Raquel, that is evidence of damage, and there was some process which we think is inflammatory, as Andrea was saying, based upon imaging studies that we have. There was some inflammation, likely the tendonitis pericapsular, that led to the damage, but we're not picking up that inflammation because it's not present to us on exam, right? And so how do we detect it? And then I think the other question is, how do we appropriately treat that type of inflammation? I don't think we know the answer to that either. Will the immunosuppressive and immune modulating therapies that we just discussed, that we use for classical lupus arthritis. Will they also be effective for the inflammation of Jaccud's? I don't know the answer. I would hope it would be wonderful if they would be effective. I don't know the answer to that, right?
So let's just go back to the case. And if you that are listening to us do not remember, the patient was flaring, and she was prescribed rituximab that she did on September 2020. And 6 months later, on February 2021, she had very mild skin involvement, just a little pink lesion on her left arm. The Jaccoud's deformities remained unchanged, and she was not having joint pain. The labs had anti-dsDNA positive, but less than a half of previous antibodies, and she had not leukopenia, and C3 and C4 were normal. And she had a SLEDAI that was reduced with 4 of SLEDAI 2K. CLASI activity was 1, and she had a lower DAS28, 2.5. And she had no new damage, just pointing that one. She was on 2.5 milligrams a day, hydroxychloroquine 400 milligrams a day, MMF 1 gram a day. So she was on low disease activity. And let's just stop a little bit to revisit now what were the patient's features. So she had from the beginning subacute cutaneous lupus, refractory to hydroxychloroquine and prednisolone. She had remitting relapsing active non-erosive arthritis that evolved on the first 5 years of her disease to Jaccoud's arthropathy damage. And she fled on belimumab. She then responded to combination MMF for a while, and now she also responded for rituximab that did not induce complete clinical remission, but low disease activity. The skin was a little bit there yet. So we already discussed a little bit of this. But if this patient presented for the first time, 22, 23, 24, would you restart belimumab, or would you start another biologic? And if she presented now, what would be your approach?
Raquel, I have no doubts. I would have used anifrolumab in these patients because of lupus, subacute lupus, skin lupus. And also, coming back to the very interesting discussion on the Jaccoud arthropathies, if it is true that she has a persistent subacute inflammation in the joints, I am expecting a better result with anifrolumab than with belimumab, because anifrolumab is much more anti-inflammatory than belimumab. It is anti-inflammatory also with an early effect compared with belimumab. And so I have no doubt that in this case, I would have used anifrolumab and not belimumab. Because again, Maria, you mentioned that, all we mentioned that the Jaccoud arthropathy was initially an active manifestation when it is not manifested yet, and then become damage. But it is also true that if you do not treat appropriately the Jaccoud arthropathy progress is not when you see it, it does not, it means not the damage, and they progress, and the patients, also the motility tend to worsen over time if you do not treat the patient. Even the patients has a mild Jaccoud, an initial Jaccoud arthropathy, you have to treat the patients very aggressively if you don't want, if you want try to abort the process.
Maria, do you have any additional comments on the case?
I agree 100%. I think that anifrolumab would make a lot of sense in a patient such as this. And I think it's great that we have more options now than we had back in 2015 or so when this patient first was flaring.
Andrea, do you have any additional comment?
I think that, as mentioned, I have used anifrolumab. I think that I do not know what is your attitude, because now we have a very serious problem when we have to treat a patient with the biologics, because we have no clear drivers on when to use belimumab, when to use anifrolumab. If you look at also the Euler in 2023 Euler recommendation, you see that they are put at the same levels. You can use one, but there are no advice on when to use one and when to use other. And so, in other words, yes, we know that the skin manifestation, especially the subacute and chronic, are one of the drivers of anifrolumab. But if you look at for example, the post-hoc analysis of the phase 3 trials, either the trials on belimumab and anifrolumab, you see that the domains which responded better on both drug is skin and joint domain. But it is and there are so what I think is that I try to look at the mechanism of action of the two drugs, which are really very different, because the belimumab is an immune modulator, and belimumab especially inhibit the adaptive immune system. And so it can dampen the antibody-mediated inflammation. That is the reason for which belimumab is a little bit slow. It is not a rapid drug. By contrast, anifrolumab is especially a modulator of innate immunity. And so innate immunity means also inflammation. One of the effector of the innate immunity is the inflammation. And so it means that anifrolumab can modulate or can dampen the interferon-mediated inflammation. It is very important because we know that the interferon in SLE is continuously activated. The interferon system is not only activated at the beginning of the disease. Probably it is one of the earliest immunological mechanism, but it is continuously activated, and so it is very important. I am not completely sure that anifrolumab can also inhibit the adaptive immune system. I'm not sure. I think that there are no data which can, but it is, in my opinion, it's not so important because, as mentioned, then the interferon system is continuously activated in SLE, and so it persists as mechanism of disease.
Thank you. Maria, do you want to add anything?
I agree. I think when you think about the pathogenesis of lupus in an overarching way, we know that there is increased activity of the and dysregulation of the adaptive immune system, right, and the production of autoantibodies, particularly against nuclear antigens. And then, as Andrea said, we have persistent activation of the innate immune system, and specifically the type 1 interferon pathway, but also type 2, type 3 interferons as well. Both of those arms of the immune system are active and they're interconnected. And the question, as Andrea said, is how do we know in a patient in front of us which of those immune mechanisms is dominating their current active manifestation? And when you look at studies from, for instance, Virginia Pasquale or Judith James, where they've clustered lupus patients based upon gene expression in the peripheral blood, you can see these clusters of patients. They've each come up with, I think, 7 clusters based upon gene expression profiles. Some patients are more B-cell predominant, some are more myeloid predominant for a given manifestation. And as Andrea said, how do we know in the patient in front of us where they fit? Because we don't have those biomarkers yet. And thus we have to just use our clinical judgment as well as the knowledge we have about some of the specifics of the manifestations to do our best to try to choose between these different biologic agents. But that is the million-dollar question right now. Until we have better biomarkers, how do we do it? And it's very challenging. I think the good news overall is that, as Andrea said, based upon the post hoc analyses from the belimumab phase 3 trials as well as the anifrolumab phase 3 trials, we can have confidence that both agents work, at least in a clinical trial setting, for both arthritis and skin. But when you look at an individual patient level, it can be challenging because we don't know what that individual patient is doing in terms of their immunology and what is truly driving their disease. So in the end, we try one, and if that is not effective, we try the other. And then the bigger question is, again, this is not approved, but is there a logic to do both? To target both the innate and the adaptive immune system simultaneously, inhibit multiple mechanisms. We know belimumab is very safe. And so I don't think that there would be a safety issue. Again, this is all unapproved, but I'm just thinking widely and broadly. I think that the future in lupus is going to be inhibiting multiple modalities in a way that is safe.
Also, anifrolumab is safe, Maria, because you have surely see the data, the long-term extension study.
Yes.
So really, the data are very reassuring. So also anifrolumab is effective as belimumab. In any case, my attitude is that when I see a patient with very active serology, with the relapsing remitting disease, I would prefer to use belimumab. If I have a patient with a persistent inflammatory manifestations, tissue manifestation, I prefer to use anifrolumab. We have some recent, we have here in Italy a registry on belimumab and also on anifrolumab, but the belimumab is, of course, we are using for a long period of time. And so now we looked at the effect on the different skin phenotypes. And we saw that, for example, belimumab is very effective in active skin lupus, less effective in subacute and chronic. And it makes sense, in my opinion, because acute is usually manifest in patients with very active disease, with active serology. And so it belongs to the, as you mentioned before, to the phenotype more induced by the adaptive immunity, where the adaptive immunity probably is prevalent. By contrast, in the other two, it is less prevalent. There is the study from the Leeds group that showed that subacute and chronic cutaneous lesions were refractory to rituximab. They do not respond to it. It means that probably in those patients, in those phenotypes, the innate immunity is prevalent as mechanism.
So, thank you so much, Maria Andrea, for joining me today. And I think we got a little justice to Jaccoud's arthropathy, which affects almost 15% of lupus patients. And I think our discussion proved it is really an unmet need, both for pathophysiology and correct treatment to prevent damage. So thank you so much for sharing your insights into this
very interesting discussion.
Challenging case.
Thank you very much.
Thank you very much.
Thank you. To our listeners, we hope this discussion have helped you gain more of an understanding of lupus. Do send us feedback on cases that you'd like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.